even the transvaginal, which is safe and is not contraindicated in evaluation of such cases, using the bladder filling. And this picture demonstrates the pitfalls that can be seen in cases of empty bladder, and the later age can be seen when a bladder is filled. Another technical issue is the use of probe pressure. Avoid excessive pressure can delineate the definite signs, especially the cirrhosis between the bladder and the uterine wall. Use of color Doppler flow mapping and power Doppler. The role of MRI in diagnosis of BS disorders, it is really out of the scope of the research, especially in low resource or low income countries, and its use is limited for parametrial invasion and posterior placenta. Prenatal screening for BS disorders started with the clinical screening through identification of the risk factor, and the most common one is the previous scars and the previous history of BS disorders, if any. Another factor is the work of such research triaging the ladies into two groups, either subjected to usual antenatal care through identification of the placenta low-lying at the mid-trimester scan and then follow-up, and the second limb including triaging into a specialized team or specialized protocol, BS protocol for follow-up of such cases. And definitely those involved in the second limb showed marked improvement and saw reduction of maternal morbidity and mortality. There are some limitations of perinatal diagnosis. It is not a histological diagnosis, definitely it is subjective, but it is the best investigation modality available till now. The sensitivity and the specificity are not 100%. Some cases we face a small invasion and have been reported in asymptomatic women, and this is of little clinical significance. Similarly, simply adherent placenta will not require a major surgery and can be managed conservatively. Is that considered failure of the perinatal diagnosis؟ بالتأكيد لا، لأن هو القصة كلها في الالترا ساوند ديتكشن is to avoid the heroic cases and so reducing the complications. The aim of perinatal imaging should be detecting BS disorders of clinical significance. In some cases, even no invasion, but the placenta is located at the lower segment, and this is definitely associated with heroic bleeding. In cases of false negative, the main problem in such a situation is the over-exhaustion of the centers for managing such cases, and even unnecessary intervention in the form of midline preparations, midline incision, or preparation of blood, or preparation of anesthetic team specialized in such situation. In case of false positive prenatal diagnosis situations as well. The recommendation for, in cases of BS disorders about the using of ultrasound, it's still the ultrasound is cheap, available, and training is simple for such cases. Risk factor screening is a simple clinical tool. The detection and the triaging of the women in the first and the second trimester is possible. The factors affecting identification of ultrasound can be minimized. The use of MRI should be limited for the cases of the posterior invasion or parametrial involvement. Now I will handle the stage for Dr. Walid to overview the management options in cases diagnosed with BS disorders. Dr. Walid.
We're going to speak about this issue now, but first of all,